So I think we are moving into an era where we're incorporating monoclonal antibodies into the frontline treatment, both with 3 and 4 drug combinations. Data are maturing, demonstrating the safety of this approach, along with an improvement in depth of response during that first year of diagnosis, that is translating into PFS benefit. So, I think we need more mature data sets, but certainly we were seeing the depth of response and PFS certainly benefiting. And more clinical trials are now looking at 3 versus 4 drug, initial induction therapy combinations. We are recognizing the importance of autologous stem cell transplant in providing patients the best duration of response and PFS in that first line of treatment as well. And then in terms of maintenance strategies, I think we are learning more about the incorporation of proteasome inhibition along with IMiDs for high risk patients, and then we're hoping that the monoclonal antibodies will come to the fore as it's part of maintenance strategy as a potential option as well. As a next step, I think it would be interesting to see how the newer novel immunotherapies, both antibody-based as well as cellular therapy-based, make their way into the frontline setting over the next few years.